Yo, hey guys. So I wanted to review patient assessment. This one says trauma, but trauma and medical are pretty much the same versus when it comes to secondary assessment. Other than that, it's the same shit. So I'm just going to use this because I didn't like the medical one. It was too simplified. And this one, it goes into detail, which what I'm used to. You see the markings? This is what I'm referring to. The other one was a little too simple. They put the airway and breathing together, and yeah, I don't know about that one. All right. So, like I said, I want to review patient assessment with you guys. Um, I don't know if somebody has explained it, how I'm about to explain it to you all. Um, the way I explain it to students and people who I train in the field is something I developed because I wasn't really explained to me how I'm about to explain to you in detail and examples and stuff like that. It was like, hey, this is your patient assessment. Know it, study it, know it, don't forget it, and that's pretty much it. And so I just want to go a little detail, more, assuming more detailed than what you will go through or have gone through in your school. And if you're in the field, then it might help you out. If you're a student, it's for sure it's going to help you out. If you're a basic, advanced EMT, paramedic, it's not going to hurt. The whole point of this video is to help you out because patient assessment is very important, extremely important. Uh, Without patient assessment, you are lost when it comes to helping somebody. And then two, um, um, it's your, how can I say this? It's a skill. And it's going to be the first skill you're going to use on every call before every other skill that you are within scope of practice. Um, so yeah, under those two um, importances, highlights, or whatever you want to refer them to, it's very important. Um, and two is the skill you will use before intubation, IV, cardiac, meds, name it. And not all calls require all skills, but all calls do require a patient assessment. And so I'm going to go ahead and just review it. Um, so we're going to start. And I might go into little tantrums. I'm going to try to control myself. Uh, but hey, bear with me, all right, guys? So we're going to start with the first part, which is this part, right? Uh, so keep in mind this is for testing purposes, but I'm gonna focus more on the real life shit. So I'm gonna, you know, not consider, you know, certain words because this is, as you can see, all this shit has to do with testing purposes, right? And you know, um, we are in the real world, right? The real test is saving a life. So all right, let's continue. Let's start and continue, I guess, right? So first part, PPE. Obviously, this should be a no-brainer. As a student or as a professional medical professional in the field, PPE is very important. A minimal is gloves, and this at any point. Usually, as you're getting on scene, put the gloves on, right? So, scene size up, this right here. What this is some of it, like this one, is when you're getting on scene, and then the other ones are pretty much on the way to scene. And this one, and this one, usually dispatch kind of takes care of it for you. But you do want to keep in mind, because sometimes dispatch does not do their job, because they're human and we're all human and we fuck up, right? So nature of illness, mechanism of injury, it could be a stroke, cardiac arrest, MVC, fall, blah blah blah, right? A type of call, right? And dispatch will let you know majority of the time, but there's rare occasions where they just send you off and they don't know shit, or they're getting the details as you're getting on scene, right? So it happens. Number of patients, they will also tell you, right, for the most part, unless like an MVC, right? Whoever the caller reports, or FDPD, whatever, whoever's on scene are gonna say it, right? But for the most part, you're gonna get it. But if not, when you get on scene, you're gonna look. You gotta count the patients, right? And for every 5 patients is 1 ambulance, stable patients, right? That's usually the rule of thumb when it comes to MVCs or mass casualties and stuff. So, all right. So then we go into additional assistance or additional resources. In other words, right? And this is where you're gonna request PD, FD, helicopter, another unit, whatever, right? And like I said, scene size sub is usually going to the call or on the call, right? When you arrive on scene, and then obviously the last part, C spine, or you want to consider C spine. Majority of the time now in this modern time of EMS, we're mostly focusing on C collar only. Backboard is optional depending on your protocol. And speaking of that, stick to your protocol. This is for educational purposes. Not so you could use this as a protocol, because at the end of the day, your protocol, your medical director's protocol, is the one who gives you permission to do certain things. This is educational purposes, in a sense of this is what we do in the company I work for, or this is the norm over here. It's all different. So, uh, be smart, all right? Don't be dumb. Always follow your protocol. If your protocol says use alternative education, this is not alternative education. This is educational purposes for entertainment, education, blah, 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 blah. Alternative education has to do with classes, like C hours that are accredited, certified, and stuff like that. So just FYI, motherfuckers, don't use me as something to practice in the field. This is something so you could expand your knowledge, your awareness, your consciousness, or enhance what you already have in you, or give you a different perspective of what you should already know, or you are going to learn if you're a student or coming into the EMS brand new, right? So just keep that in mind. It's a disclaimer. Fuck off if you're going to blame me if you fuck up. All right? This is not my motive. This is not my intentions. My intentions is just to educate. So forgive me for the tangent, but just want to throw out there a disclaimer. So let's continue. Majority of the time is C collar for us where I live in the area. Backboards, and I think it's the same thing everywhere else as far as nationwide. Backboards are not really indicative anymore. They found that they actually cause more harm than actually prevent harm. So backboards for us, the company I work for, our protocol states backboards are only to move patient from one location to the other location, which is then the stretcher, and then you remove the backboard. The only time I keep the backboard on a patient, based on experience and based on the call itself. Remember, we're treating patients. We're not treating numbers. We're not treating, we treat patients based on what they need, depending on the call. Remember that shit. So going back to backboards, I usually keep a backboard on patients who fell off buildings. I tend to keep it just to prevent any further spinal injury, especially patients who have partial spinal fractures. And how do I know that? Well, I do an assessment before I move the patient, and this is when we're looking at, incomplete spinal fractures, where we do light touch, sensitive touch, and stuff like that, right? So let's continue, right? So for the majority of the part is just C-collars and stuff. And this one you want to consider, falls, MBCs, traumas, stuff like that. So let's continue. And this is where it gets. I mean, obviously everything's important in this, but I want to emphasize extreme importance on primary assessment or primary survey. All right, this is very important. According to this statistic that I'm about to quote, that I saw about 9 years ago from NREMT website, and I don't know, I haven't seen it since then, I haven't kept up with it, but according to them, 90% of all emergencies can be taken care of just with primary assessment. All this right here. Okay, and this has to go in order. Not only in the testing phase when it comes to at school or the national test, but in real life too. And this is where I speak of in a personal matter with 10 years of experience, many saves under my belt. I've used this patient assessment just like this from school, no alterations, on real life, where I tell you this works. And I believe that statistic because I've been practicing it. I trust it, I lived it, and I still use it to this day. All right, so this is where we're going to get heavy on this video. So primary assessment, this is pretty much you're already on scene. Like I said, this part right here, we're driving, we get there, boom. We look at the scene safety. Obviously, we know this. It could always vary. Understand that it is when you enter scenes, they're never guaranteed, right? There is no safe scene. If they tell you scene safety, secure the bullshit. There ain't no safe scene. It's always unsafe. And just because nothing happened doesn't mean it was safe. It's just you weren't there or it hasn't happened yet. But it will happen. Every scene is unsafe. So always keep your situational awareness. Always be alert. Always be ready. Adapt and overcome. Understand that, guys. So like I said, we're pretty much driving, arrive on scene. We're reassessing everything that whatever information dispatch gave us or didn't give us. And now we're here. We're on scene. And this is where we're going to start. And I'll highlight it in blue. So, 1, as you can see it on the video, right? Hopefully. 1, fuck the verbalizing shit. General impression of the patient, right here. What does that mean? This is quick. This is easy. You're going to look at the patient. You're going to look at their presentation. Are they sick? Not sick. Are their eyes closed? Not closed. Are they breathing? Not breathing. Do they need help? Yes or no? That's it. 10 seconds, 5 seconds, whatever. And this is mostly subconscious thing, right? You're going to like, hey, something's wrong here. Or a patient's not acting right. That's what it means. Right? And then you move on to number 2. And I'm going to say this now, and I'll keep saying it throughout the primary assessment. You are not allowed to move on to this part unless you finish this part first. And this is where I'm going to say check off. Check off. So let's pause the assessment part, and I'm going to speak of check off. I'm sure you've been told, if not yet, you will be told, and whenever you took your school, you probably have been told, don't treat your patient as a check-off list. Yeah, go fuck yourself. Because it is a check-off list. For me it is, and it should be for everybody. Because your job is, when you arrive on scene, your job is not to be friends with the fucking patient. Your job is to make sure they're okay. How can you help them? And how do you do that? You check them off. And what are we checking off? We're checking off mental status. Well, let me fix that. We're checking mental status, chief complaint, life threats, airway, breathing, circulation, vital signs. Right? Right here. Vital signs. Right here. Vital signs. Yeah, it's a fucking checkoff. Now, I'm not saying be cold, be a robot, be an asshole. No, bedside manner goes a long way. And I'll write that shit down so you can keep in mind. Bedside manner is important as well. Alright, bedside manner goes a long way. But this bedside manner does not mean, or I'm saying, my bad. This does not mean to get rid of this. No, you could be nice and you could do check off, right? So that's what I do. I check off, right? I know a medic personally who still works as a medic. He has 20 years in the field. He adds bedside manner and check off method of approach at the same time. And I'll give you examples. Hey, sir, how you doing? Doing okay? And the patient responds. He's looking for mental status. He's looking for mental status. He's looking to see if they're responding correctly based on his interaction with him. You ask him, hey, so are you from here? Like, this is a beautiful house. This is a nice car. Wow, this is a nice shirt. Wow, blah, 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 right? Like, he's being personal. He has bedside manner. He's becoming personal with the patient. But he is checking off all this all at the same time. And that's his way. That's his personality. And that's okay. That's not how I am. And this is another point I'm going to emphasize is that when we do these skills, when we do assessments, all this shit should not be any different than the next medic you see, the next medic you ride out with, the next medic you work with. What should be different is personality, right? It should be different, right? Like, I may be more cold, more direct. He may be more warm, blah, blah, blah. And that's okay. As long as we're not rude, right? As long as we get to do our job. But all this right here should be the same. So, going back, check off. Yeah, we're gonna check it off, and that's the whole point. And I'll leave this things here, just to so you could keep that in mind, because that's all you're gonna see right now. Check it out. So let's continue. So we checked off the first one, general impression. Patient sick, right, or not sick. Then move on to section 2, because we checked it off. And I'll put a fucking blue check mark right. Boom, checked it off. So now we're going to determine responsiveness, level of consciousness. Okay? And I'm going to explain to you why there's two things, because these two things are two different things. Okay, so let me clear the board here so we won't get confused. Right? I'll put a smaller check off, and then I'm going to write here. This is going to be our area where I'm going to make notes. Screenshot it, whatever the fuck you got to do, because they're going to be erased once I move on to the next section. Alright, what is level of responsiveness? Right, or responsiveness, which is this. LOR and LOC. Level of responsiveness, level of consciousness, as you can see there. So LOR is pretty much a poo. And I'm sure you've seen this around. Alright. A stands for alert, B stands for verbal, P stands for pain, U stands for unresponsive. Okay? So level of responsiveness, and I'll give you an example, right? You get on scene, you're on general impression, patient has their eyes closed, right? They're breathing, let's say, normal, right? So you're going to go up to the patient and you're going to make contact. You're going to check their level of responsiveness. So alert obviously tells you, mark it I'll mark it as I'm going through it, right? So on your first general impression, you noted that the patient has their eyes closed, right? And so when you make contact with them and you're going to check for responsiveness, it's like, sir, right? But before you say sir, you're looking at them and they're not opening their eyes. So they're not alert, right? They're not spontaneously looking around, alert, right? Looking, being aware, right? So that's when you use your verbal stimuli. This is where you're going to say, you're going to check where you're verbal. And so when you're going to say, sir, now do me the fucking favor and don't be that fucking idiot who does, sir, and at the same time you're touching them. You're doing painful stimuli, which is the P part. Because now you don't know which one is it. Is it the verbal or pain are they responding to? And that, there's a big difference, right? So, don't be that fucking person. So now you continue. They're not responding to verbal. So you cross it out. Then you're going to do painful stimuli. And then painful stimuli is either just a simple touch, move, right? Or you do a sternal rub, which you're rubbing your knuckles on their chest. Or you could do squeeze their shoulders, their nails, and stuff like that, right? If they don't respond, then they are unresponsive, which is the U part. All right? So the patient's unresponsive. And this is the only time where the patient assessment, primary assessment changes. Instead of A, B, C's, which are these, now goes into C, A, B, which is the same thing, it's just a different order. Circulation, airway, and breathing when it comes to unresponsive patients. Why do we do that? Well, to keep it simple, and this is how I'm going to explain to you. In EMS, there are two things that we do, and we should do at best. One, we are the UPS FedEx of human beings. Our job is to arrive, package, transport from A to B, and whatever happens between A and B within our scope of practice, we do it. We can't do it, we report it. And whatever signs and symptoms we see, we also report it. We get to B, destination, we drop them off, and we did our job. That's part one. Part two is we are buying time or we are subtracting time. Meaning in what? In this case, why are we not doing ABCs when it comes to unresponsive patient? Well, because it will take time to get from, it would take time to get from airway all the way to circulation, which is right here. What does that say? Check pulse. It may be 30 seconds, maybe a minute, maybe less than a minute. But that's less than up 30 seconds up to a minute. And obviously I'm exaggerating, more like 30 seconds, right? Which 30 seconds without air is a big fucking deal, right? So we are switching from ABC to CABC, right? Why? Saving time. Or I like to say shaving time. For what reason? Buy time. Alright? That's why we fucking do that. It's so we could shaving time from this to here. We erase that shit. We go straight to circulation because we're buying time. For the sake of who? Patient. So this is the only time where primary assessment switches from ABC to CAB. So let's say we do that, right? We have a responsive patient. We go circulation, airway, and breathing. They do have a pulse. All right, great. Now we go back to this, and actually this as well. Mental status, right? Or correction, my bad. We go to this now. Level of consciousness. All right, you guys following along? I'm trying to keep it very simple, very straight. Okay? But if patient has no pulse, oh shit, my bad. No pulse, then what do we do? Right? And this is where we continue with this. What do? C, compressions, A, OPA, B, oh shit, my bad, BVM. So, going back to why do we do the patient assessment? Because I said it's important, right? Well, why is it important? Well, we're going to pause this explanation. Let's go back to patient assessment. What is patient assessment, right? Why is it so important, Tony? Well, let me explain to you, persons who are watching this shit. Patient assessment is so important because, one, it is a map. What map, right? This is the analogy I'm going to use for you to understand. You all travel out of your city, to a different town, to a different state, right? How do you know that? How do you know to go from one place to another place? And to get there, right? You follow a map. You follow Google. You follow fucking Apple Maps, whatever, right? You follow the roads. You follow the signs. Okay, patient assessment is the same shit. This patient assessment, trauma and medical, are a map to what? Helping a patient. Without this map, you are fucking lost. You will never get there. And you're going to be hurting this person. Person 1, 2, 3, 5, 10, whatever patients. Patient assessment doesn't change in the amount of patients, right? You have 5, you have 1, you have 10. Same shit. Patient assessment does not change. And this is where I'm going to later emphasize why you're going to encounter individuals in the field who are afraid of certain calls, pediatrics, OBs, or whatever. Why? Because majority of the time, they don't know their patient assessment. They don't know the skill, because it is the skill. So, I'm not going to go into a tangent about that. I could go at that at the end or whatever the fuck, but for right now, let's focus on this. So, patient assessment is the map to helping a patient, and then 2, you'll know what to do in a chaotic scene. You'll know where you're at, what is going on, and what do you need to do next. And then 3, patient assessment will tell you what skill to do, when to do that skill. And this is where we go here. We go back to this lesson right here. Without patient assessment, we wouldn't know this, and we wouldn't know what treatments to give. All right? Capiche? Understand? That's simple. So yes, patient assessment. Everything that you're learning, I'm talking to you student guys, or girls and guys, whatever the fuck, transgenders, whatever the fuck you guys want to, identify as. It doesn't matter whatever you identify is. Your identification is. Patient assessment is the same shit, all right? Fuck, I lost my train of thought. My bad. What the fuck was I saying? Ah, damn it. Anyways. Oh, yeah, all the skills that you're learning in school, this goes for the students, right? Or the rookies in the field. All the skills you learn, and the students, all the skills you will learn, all align to patient assessment. And I'll give you a quick example. I, as a paramedic, the highest level in the field, I will always start the same patient assessment. And let's say I'm a basic, right? I start all my calls as a basic, no matter what. I'm not gonna go automatically fucking intubate or RSI, rapid sequence intubation, right? A patient ain't there, right? We start basic. So patient assessment will tell you what skill. Oh, that was an accident, but what skill? When to do that skill, right? Airway, suction, suction's the skill. We're gonna suction. Airway will tell us that we need to suction, and if suction doesn't guarantee an airway, then we have to put something in it, right? OPA, MPA, crike, right? Manual maneuvers. And obviously, we go from basic to advanced, then to paramedic. And obviously, in this case, suctioning are all levels. OPA, MPA are all levels as well, basic, advanced, and paramedic. But the only thing that is different is crike. That's a paramedic level skill. How would I know to upgrade from OPA or manual maneuvers, OPA, or to crike? Because I can't secure it. There's a foreign object. There's an anaphylaxis patient. The throat has completely swollen up, right? When do I know how to do that? Airway, patient assessment. So this is what I'm referring to. The patient assessment will tell you what skill and when do you have to increase that skill to a different level. Other than that, you're fucking lost. So this is what I'm referring to. Compressions, OPA, BVM. How do I know how to do this? Because of this. Alright, so going back to the lesson. So now, like I said, this is the only time the primary assessment switches is when the patient's unresponsive. We go from ABC to CABC. Patient has a pulse, we go back to ABC, and then we continue with the bracket, or this step 2, which is now we do level of consciousness. Patient has no pulse, then we continue with CABC. Compressions, OPA, BVM, and then the rest. Pretty simple, right? It's not difficult at all. Hopefully this is kind of like, holy shit, it all makes sense now, right? Alright, let's continue. I'm going to erase this shit. Let me see, where is this shit? Alright. And we're still on there. Look at that. We're still on the second part. We haven't even moved on to the rest of the fucking page. It's okay. So now we're going to do level of consciousness. And this is where, we'll do COA times 4, AAO times 4, or CAO times 4. Alright, let's break it down. Conscious, oriented, and alert times 4. Alert and oriented times 4. Conscious, alert, oriented. Whatever the fuck you want to use, it's the same shit. But what is times 4? And this is where I'm going to go. Name, time, event, place. That's what this is referring to. And that is part of, I'll show that. That's part of this. So we did this level of responsiveness. So, quick question. Patient unresponsive, are you able to get a fucking COA times 4, CAOA times 4? No, you're not, dude. You're not. Right? So then what do we do after that? We're not done yet. Now we go to GCS. Oh shit, my bad. Right? The minimum is 3, the highest is 15, which is 5. My bad. Which is 4, 5, 6. Right? When you add them up, is 15. Right? And then the minimal, which is 1, 1, 1, which is equals 3. That's how we get this part right here. And I'm gonna I'll show you right now what I'm referring to. Alright, stand by. Boom, boom, look at that. Look at me being all nice and organized. Boom, these are all my notes. Okay, so this is my field guide, and I'll go into detail. I'll go into detail later on about it, but let me erase this bullshit. Okay, so GCS. Here we go. Alright, GCS, which this may be familiar to you guys. And this is for students, right? Or I guess rookies. You seasoned fucks should already know this shit. But let this be a reminder, alright? Remember level responsiveness, right? We use AFPU, alert, verbal, pain, unresponsive. Well, that correlates to GCS. Alright? So what is this? Look at that. I. 4, 3, 2, 1. We're going to eventually add numbers, but this is where we go. A, B, P, U. So the first part, level responsiveness, you already did this part when it comes to level consciousness and GCS. Right? Same thing. Speech, pain, no response. Then we continue. Verbal. Are they verbal? So if you have an unresponsive patient, which, you know, that was a part of the lesson over here, right? Unresponsive, you're not going to get a COA times 4 off this shit, but you still got to continue. Over here, so we skip to this. Obviously, no. Confused, no, because they're unresponsive. But they may react to words, they may add to sounds, or they may not react at all. So then we go from no response, that's 1, 2. And in mortar, are we going to obey commands? No. Are we going to localize pain? Probably not, because they're unresponsive. Withdrawals for pain? Yeah, you could get that one. You could get that one, right? You could get this one, flexion, extension. They're all involuntary reactions. Or we could get this one, and you add them. So now you have 1, 2, 3, and that's how we get. And that's how we get GCS of 3, which is no bueno, no good, not good at all, right? And then we go back, let's say, so the highest is 15, so we do is 4, 5, which is 9, 6 plus 6 is 15, which is the highest, and that's good. Alright, so that's GCS, level of responsiveness, level of consciousness. Alright, guys, hopefully that helps you guys. Oh shit, my bad. Hopefully that helps you guys. So now, since we check this off, oh my god, look at that, I said check off. Alright, now we can move on to the next. And this is where I'm going to explain number 3 part. Chief complaint, apparent life threats. Why is there 2 different things, right? Alright, so if you have an unresponsive patient with a GCS of 3 and COA times 0, are you going to be able to get a chief complaint? No. What is chief complaint? Chief complaint, remember this shit right here. Right here. Chief complaint comes from the patient. Bop, bop, bop. Alright, chief complaint comes from the patient. You're going to encounter people who are going to say, oh, chief complaint of MBC, chief complaint of stroke, chief complaint of OD, chief complaint of general body weakness. No. Well, general body weakness could be chief complaint, right? It could be a type of call and then also a chief complaint, right? Chief complaint of, let's see, fall. How the fuck is that a chief complaint, right? Chief complaint is what the patient is expressing their main complaint is about. You can have NBC. You show up on scene, patient is complaining of chest pain because they hit their chest on the steering wheel. Which one's the chief complaint? Chest pain. Traumatic chest pain. You understand that? You're only going to get a chief complaint if you have a conscious and oriented patient. Other than that, you're not. You're not going to get one. If you have an unresponsive patient, you're not going to get a chief complaint. So don't look like an idiot when you go in the hospital or whatever and say, hey, chief complaint of NBC, a chief complaint of a stroke, chief complaint of a fall. Like, no, dude. You just... And the person who says, okay, sounds good, and then put it down, they're as idiot as you are, right? So let's continue. So we can't get a chief complaint, so then what do? We look for life threats. Why are we looking for life threats? Because patient can't tell you what is wrong, so you have to look for what could possibly cause them to be unresponsive. Duh, right? That makes sense, right? And this is a quick scan. This is where you could do a quick secondary assessment. This assessment right here takes time. The one I'm referring to over here, life threats, looking for life threats, quick assessment. It's just a quick scan. Just remove the clothes or look under the clothes for anything such as broken bones, flail chest, broken skull, blood, whatever. You're trying to find something that could possibly explain why the patient's unresponsive. Right? That's just pretty much it. That's it. There's no more to it. Very simple. Why? Because patients are responsive and we can't get a complaint. We don't even know what's really happening, right? And this is where, it could be a medical call, it turned into a trauma call, it could be a trauma, then a medical, right? So this is why I'm using this patient assessment for both, because the trauma assessment is more detailed than the medical assessment. So let's always go extra, right? It's not going to hurt you, it's not going to hurt the patient. So you're taking the extra measure. All right, let's move on. So now we did that. Oh my God, look, check off. We're done. Now we can move on to the next part. All right, so this is where I'm going to take this moment and emphasize this part right here. Why are this before this, this before this? And this is my own understanding. Nobody explained this to me, but this is based on observation, experience in the field. So, why are we checking for level of consciousness and level of responsiveness before airway, breathing, circulation? Okay, 2 reasons. 1, patient, right? And I'll write it down for you guys. Patient. In this case, let's choose nature of the illness. So if the patient's unresponsive, or if, let's say, they're just confused, right? They're alert, they're conscious but confused. Why are we checking this first before everything else? Well, because 1, it's an indicator of how bad the disease has gotten to the point to reach the brain. It could be cancer, it could be sepsis, it could even be drugs. It doesn't have to be illness. It could be drugs. It could be, it could even be trauma. It could be a fucking hit in the head, right? It could be a stroke. It could be a hemorrhaging stroke, ischemic stroke. It could be drugs. It could be carbon monoxide from a vehicle. It could be uppers and downers. It could be alcohol. It could be fucking tumor. I mean, name it. But diseases are not acute. They're not quick. They're slowly, progressively to the point where it gets bad, right? Where you're confused. You're not alert anymore. You're not conscious, right? Just depending on the degree. So that's why we check that first, because then it will tell us, man, if they're alert and they're oriented and they're sick, okay, disease is not that bad. We have time to figure out the symptoms, manage the symptoms. We don't have to rush through the call. Patient's confused, and once the patient's confused, the brain is touched by disease or trauma or whatever. Remember what is the brain? Brain is the computer. It tells everything else in the system how it should be and how it should work. If the brain is touched by trauma or medically by illness, then everything else, all this, will be affected. Because all these centers are in the brain, and right here, brain. And that's what we're checking when it comes to this. We're checking the brain. It's a neuro check, right? And all this is here. So if the disease starts in the kidneys, in the GI, or in the liver, the disease grows, the cancer, whatever, grows, and then this is the head. We'll eventually reach this, and then we'll eventually get to this. So this will tell us, fuck, we are going against time. Unknown time. We don't even know the time. We don't know how much more time before patient completely dies on us. And then you have a cardiac arrest patient. Right? And this is where I go back to. What do we do in EMS? We package humans from A to B, and we do what we can do between A and B. And then 2 is we're buying or we're shaving time. In this case, what are we doing? We're trying to buy time because we don't know how much time they have before it gets worse. So that's part 1 of why we do level of responsiveness and consciousness before ABCs. And then 2, let me erase this shit for you guys. All right. Boom, boom, check off, check off, check off. Part 2 of why we do that is because if you have a confused patient, how are you going to be able to get chief complaints? How are you going to be able to get accurate information, history, which is this part right here, right? How are we going to be able to get the history, right? Assess the problem, assess the chief complaint, right? OPQRST, right? How are we going to do that if the patient's confused? So then what we got to do is find somebody who called EMS, family or something, a witness, and hopefully we could get answers to all that. And if not, then we do what we can and we transport, as long as we maintain primary assessment. Right? So that's why we do that. This is why it's prioritized the way it is. This is why we do mental status check before airway and breathing circulation. And this is why I tell you why you got to do this in order. Because they all correlate with each other in order, right? So then, going back to the lesson. Now we do number 4. Oh, my bad. Number 4, airway. Now we've taken care of all this. We get our, COA. Oh shit, my bad. Keep forgetting to switch this shit. COA times 3 GCS of 14, which is pretty good. Not too bad. Now we move on to chief complaint and whatever they say it is, right? And then we move on to airway. And this is This is where I do all this all at the same time because over the years of experience, I'm able to, you know, seconds do all this shit, right? As I'm assessing my COA, right, name, time, place, event, and my chief complaint, I'm getting my airway, the way they're answering, right? My breathing, as how they're answering, and I'm looking at their chest, and at the same time, I'm checking their circulation, their skin condition, looking at their lips. Um, let's see what else. The fuck, I'm drawing a blank right now, guys. Um, Skin color, right? Stuff like that. That's what I was trying to find. The skin color and stuff. So I do all that all at the same time, right? But that's me, right? I'm already at that level where I've done it for years, and I don't have to break it down little by little bit. But in the beginning, I did. I took my time. Trust me, dude. Before I touched the field, I was obsessively fucking studying this shit, imagining it in my head, practicing it in my head, and then I went out there and did it, and no problem at all. So I could do it. You all could do it. I'm not special. All right. So let's continue. So now we go to airway. Open, assess airway. Well, in this case, right, like if the patient's unresponsive, then you would have to open it, right? You have to check it to see it's clear. There's clear fluids. There's no blood or anything, right? If the patient's alert, then obviously they're talking to you, right? You don't have to open it, but you do have to look at it to see, just like, hey, does it sound clear? There's no stridor. There's no gurgling, right? Stuff like that. And if it is compromised, then what do we do? This thing says, insert in this case will be OPAs and PAs, right? But that's for unresponsive patients, right? Well, let's say it's not clear. What do we do? Suction, right? That's it. That's our first skill. When it comes after the fact of patient assessment, we suction, right? And so, so we clear that off, right? We check it off. Check, check. We don't have to do anything to the airway. Airway's good. Now we can move on to the breathing part. And this is where I'll do number 5. Breathing. This is what it says. Just look at the breathing. And this one doesn't say it. The other patient assessment form that I've looked at many years ago was very detailed in the sense of, when it said breathing, it says, is it present, rate, quality, rhythm, and depth. This one just says fucking assess breathing, right? Adequate ventilations, right? Which is pretty much the same what I'm referring to, but I just simplified it here. And then, like I said, you can move on to the next until it's checked off, checked off, checked off. Each bracket needs to be checked off before then you can move on here. So, breathing, rate, is it present? Ask yourself these questions. Is it present? What is the rate? What is the quality? What is the depth? And what is the rhythm? Is it regular, irregular, right? Depth, is it normal? Is it shallow? Is it rapid? Quality, is it long deep breaths? Is it short breaths? Stuff like that. Then we move on. Ventilation, adequate ventilation, which is pretty much the same thing, right? The depth of it, quality of it. And this is kind of where you're going to BQ mismatch, but it's that's critical care. I'm not gonna go. I don't want to confuse you guys, but so now we go back down. Then we check it off, right? Check off, check off. If these at any point are and like I said, this one doesn't have SpO2%. The other patient assessment form that I used did say it, right? We look at SpO2, and then we consider oxygen therapy. This is where you use a non-rebreather or nasal CPAPs. So this is what I'm referring to. I hope you're understanding that patient assessment will tell you what skill to use. Right? Simple, right, guys? Hopefully you're following, because I don't think it could get simpler than this unless I fucking show you in firsthand, right? But even then, I mean, let's continue. Fuck it. And then we check off, check off, check off. We put an armor breather. We suction up here. Something's wrong with the breathing. SpO2 is low. Boom, oxygen therapy. Patient's on armor breather. 10 liters, 15 liters. Now we go into, well, what's causing the breathing problems, right? Is it shortness of breath? Is it asthma? Is it something? Is there anything impeding breathing? Trauma to the chest, trauma to the back of the torso, or the torso, head injury, right? Bleeding in the ears. Like what is there anything compromising breathing? And mostly in the chest, right? Like, you know, is there a fucking knife? Is there a bullet hole, right? This is kind of where you do a quick scan. Oh my God, quick scan. What does that mean? Right here. Life threats. General impression. This is why we do this, because all this will back this up. And you're buying time for the patient, and you're shaving time. Because you're not wasting time. Oh, let me do this first, and then okay, oh shit. You know what I mean? I hope you understand why this is here, following this system. Alright? And this is why I'm telling you, primary assessment must be done in order. And 90% of all emergencies can be taken care of with just this part. The rest is a walk in the park. As long as you maintain this, everything else is simple. The call is simple. All this is extra that you need to do, but your main thing is this. If this is compromised, do this as much as you can, but don't forget this part. This includes IV, this includes fucking medications. ABCs must be always maintained. Always. Without this, patient will die. Patient can live without secondary assessment. Patient can live without vital signs. But they will die from airway breathing, major bleeding. Shock management, right? Shock symptoms. Alright, so now we check it off, and I'll actually mark it. Check off, check off, check off, check off. Now we go to the sixth part, circulation. And this is where, same thing, we're checking for a pulse. And remember, the only time primary assessment switches is when you have a non-responsive patient. Goes from circulation, A, B, right? Circulation, airway, breathing, CAB, right? Versus ABCs. So we're checking for a pulse. Pulse is present. And this is where we do the same thing for breathing. We go in deep. Is a pulse present? We ask the question, is the pulse present? Yes. What is the rate? What is the rhythm? What is the quality of the pulse? Right? Then we can move on. Check. Now we look at the skin. What is the skin condition? Is it clammy? Is it clear? Is it hot? Is it cold? Is it pale? Is it pink? Is it hot? Is it flush? Right? What is the temperature? Once we do that, we could take off, right? Check it off. We go on to the next one. Is there any bleeding? Major bleeding. Right? Is there bleeding on the chest? Is it bleeding on the neck? Is it bleeding on the arterial bleed, the radius, the under the armpit? I mean, name it. And if there is, what do? We do something about it. Without it, if there's something, then we move on. We check off. And we check it off. If we do something about it, we're able to control it. I need to emphasize on these, right? We cannot move on until this is taken care of. Airway is not clear. We suction until it is clear. Okay, now we can move on. Okay, airway is not controlled on its own. We got to do something about it. We cannot move on until it's controlled, either by OPA, NPA, whatever, right? Intubation, whatever. Breathing, same thing. So that's the whole point. We cannot move on to the next sections until it's taken care of. It's treated. If it's not treatable, we keep treating it and we transport. This is why we have patient priority makes treatment transfer decision based on cognitive GCS. And it's not really just GCS, but it's all this as well. ABCs, CABCs, okay? So now we move on. Now we did the major bleeding, we controlled it, or we didn't have to do anything. We move on to shock management. And what is shock management? Very simple. Patient cold, warm him up. Patient hot, cover him up. And that correlates with temperature, that correlates with circulation, that correlates with breathing, that correlates with brain function. Right? And that's that simple. That's it. Once you're done, you move on. If you can't control it, we do something about it, and we then go to the last part. This is where we go, number 7. We have to prioritize the call. This is what I was telling you. Patient assessment is not only the map to helping a patient, but patient assessment also will tell you when, what, where, how, and it will also help you prioritize the patient. Red, yellow, green. Right? And this is where we determine, hey dude, this patient is completely fucked up. We gotta rock and roll. We take off. And then we're gonna go ahead and just maintain all this en route from A to B. And we cannot move on until all this is checked off. If all this is good and clear as we're transporting, then we can move on to the rest. Right? But if not, we focus on this. Oh look, we got to B, which is the hospital. We give her a report. We transfer care. We maintain life. We bought time. We shaved time by doing this. Right? Oh my God, simple. And that's what we do. That's EMS right there in a nutshell. So now, after all this shit's done, we determine priority of transportation. If you haven't heard this phrase, you heard it here now. Load up and go, or stay and play. Load up and go means this patient is critical. He's red. We must go maintain ABCs all the way to the hospital. Stay and play is, okay, patient's not that bad. It's not too critical. I can manage this. Airway's pretty good. Breathing's okay. Circulation's okay. Let me prevent him from getting worse, or her. Let me stabilize the patient. And I could stick around a little bit. 10 minutes, 15 minutes, 20 minutes, whatever. Okay, now I can move on because I've done all this. I've done all this. And I've done all this. And I could just, reassess en route. Let me buy them time. Let me shave time. That's it. Right? Simple. Okay, so let's see. Let me use this patient assessment now, because I notice for certain parts it doesn't emphasize. No, fuck. Let me see. Oh, it's still the same. Okay, let me. No. There we go. Let me use this one because I noticed on the let me use this one because I noticed on this one, this part right here. I'll finish this, but I'll continue over there because it's a little different. So now we've done this, right? We check this off. This is where we do our history taking, and we obtain our vital signs. This is where I'm going back to where the one I used in school and the one I would use to teach students who rode out with me on the field, and I precepted employees and stuff that had indeed to the vital signs. Vital signs is just not this right here, which is BP, pulse, and respiratory. It's that plus SpO2%, blood glucose, and then temperature. Those are the vital signs. I don't know why they fucking just did 3, but whatever, dude. I'm changing that shit for you guys. We obtain the vital signs. We obtain sample history. What is sample? Signs and symptoms, allergies, medications, pertinent history, last oral intake, events leading to illness or event. That's what sample means. This is where you also get your OPQRST, right? Onset, provocation, quality, radiation, severity, time. Make a note. Time does not mean how long you've had it. Time means have you had this before. All right? And this is where the medical, as you can see right here, OPQRST. Right? So that's the difference between the trauma and medical. But honestly, you're gonna use it either way on traumas too, because when did you did you have that knee pain? Did you have that chest pain before the MBC? Oh yeah, you did. Or when was that? How long ago did it start? What makes it worse? What's, you know what I mean? Like, so I don't know why they changed it up, but or they divided it. But you're gonna end up using it on trauma. You're gonna end up using it on medical. So, anyways, let me go back just to finish this shit since we're already here. OPQRST. Now let's make a note. After primary assessment must be in order. The rest does not have to be in order. It just needs to be done at any point from A to B. All right? Just get it done. There's no order to it. Just get it done. ABCs or primary assessment, there is order. Must be followed. So this is where we get this, vital signs, OPQRST, sample, and then in case trauma, we're going to do a head-to-toe trauma, right? We're going to check from head, even if the patient's alert, even if the patient's walking around. You have to be the eyes for the patient. Remember, you are the professional. Patients don't know. They're concentrating on the fact that they almost died. They're concentrating on the fact that things could have been, what ifs, and whatever. They're not aware of their injuries. We are the professionals. We must check. Do you have to cut the pants and the shirt of every fucking conscious patient? No. But you could just look under it and just explain to them that, hey, ma'am, sir, I'm going to have to check under your shirt for any injuries. This is for your good. This is to help you. And majority of the time, like, go ahead. Like, yes, please, help me. You check it and just cover them back up. Cover them back up. The shock management, right? You're trying to bedside manner plus shock management. You don't want them to be exposed to the cold, especially during summer. We have the units blasting cold air. You know, patient needs to be fucking. You know, their temperature needs to be normal, because then there's different effects to the system if they're cold or too hot, right? So this is where we do a head to toe. We check for everything. D cat B. Oh fuck! I forgot. Fuck. D cat. We look. Yeah, I'm drawing blank again, guys. We look for deformities, contusions, avulsions, abrasions, punctures, burns, lacerations, and then swelling. Oh shit, no, that. D cap, P. Fuck, my bad, guys. I'm getting confused with the erasing part. D. So what I said: deformities, contusions, abrasions, avulsions, puncture wounds. B, burns. D cap. T, which is tenderness. LS, which is L for lacerations and swelling. Decapitated TLS. There we go. There we go. Forgive me, guys. Forgive me. And this is where we use this on secondary assessments with traumas. This is what we're looking for. deformities, contusions, avulsions, abrasions, punctures, burns, tenderness, lacerations, swelling. This is where we are the eyes for the patient. All right, cool. All right, and what are we doing here? Check off, 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 check off. All right, pretty cool, right? I hope this is helping you guys. You guys kind of understanding, and your confidence is being boosted right now. All right, so now let's go to medical assessment, and it's just going to continue because the patient assessment, the primary assessment is the same thing. This is where it just emphasizes more. As you can see here, allergies. This is the sample of the trauma, right? So just put them together. Don't think, oh, trauma assessment, medical assessment. They're two different things. No, just put them together. All right. Understand we have a trauma patient because, like I said, you may have a medical call turns into a trauma, or a trauma that turns into a medical. Right? So just put them together. Understand that you have to check for all these things. So history taking, like I said, OPQRST, sample. The difference between trauma and medical is that you don't do a full head to toe assessment. You do a focus assessment. So when it comes to over here, patient is alert, oriented, complaining of chest pain, non-traumatic. So then what are we doing? We're checking for cardiovascular. We're also checking for pulmonary, anything that is close to the system. All these are systems, guys. Cardiovascular, pulmonary, neurological, muscular. They have their own systems. You have to, when you're checking for lung sounds, like let's say shortness of breath patient, not only are you checking for lung sounds, you're also checking for the heart. Why? Because it's right next to each other. Associated symptoms to the chief complaint. And this is where you do a focus assessment. You're not going to check their fucking groin. You're not going to check their toes. You're going to check to what they're complaining about. They complain about the arm. You're going to check the arm. You're going to check the ligaments. You're going to check the shoulder. You're going to check the skin, the muscles, right? They complain of the chest. You're checking the chest, the muscles, the lungs, the heart, right? The neck. It's all associated there, right? So that's pretty much what that is. And remember, this part right here can be done at any point. But this needs to be in order. Check off, check off, check off, check off. All right. So, this is the part that changes a little bit, but then has the same shit. This is where we go. This is where we do vital signs, obviously. I don't know why this is there. Scratch that bullshit. Alright, EKG, this is for MICU, 4 lead, 12 lead, right? This is where you make a diagnosis as a paramedic. You give treatment. Anytime you give treatments, you have to reassess. This is why we have to have a baseline. We do a patient assessment, we get a baseline, we find the things we need to fix, we give treatments, then we reassess. And when I reassess, when I say reassess, we're reassessing from primary assessment all the way down. This needs to be done too whenever time you give treatments. Onset provocation, because you want to see the differences. Are you helping? Are you improving? Or are you making it worse? Or you're just, not doing anything, right? Neutral. You're neutral. Nothing's helping. Nothing's getting worse. So we give her treatments, which is right here, treatment plan for interventions, and then we reevaluate. At this point, for majority of the time, if it's not a priority call, all this is done 10-15 minutes on scene. This is where we stay and play 20 minutes depending, and then we are already taking off. That's how I roll. If it's a critical call, I'm managing primary assessment, I'm giving treatments, I'm reassessing all this. It's within 5 minutes, 10 minutes. I'm rushing. I'm I'm going. I'm working, dude. I'm working hard. This is where my partners matter. I'm gonna fucking stabilize this patient, and once stabilized, then I can make a decision. Okay, let's haul ass, or let's see what's up. But that's me. That's where I'm at right now, where I could do all this in 5 minutes, man. That includes treatment. At the 5 minute marker, 6 minute marker, I'm reassessing everything again: mental status, airway, breathing, circulation. I'm comparing it to my baseline. Boom, patient stable, patient semi-conscious now. All right, let's take off. Let's take off to the hospital. If anything gets worse, I'll update you. I'll tell my partner that's lights and sirens, or nah, we're good, man. Let's continue how we are. But that's me. That's where I'm at. I could do all this 5-6 minutes. I'm fucking pushing, dude. I'm managing airways. I'm managing breathing, treatments, oxygen therapy, EKG, 12 lead. I'm giving meds. I'm giving cardiac meds. I'm reassessing. I'm giving fluids. Boom, boom, boom. Reassessing. By that point, 6 minute, 7 minute marker. Reassessment's good. Reassessment's the same as the baseline initial assessment. All right, dude, let's rock and roll. I'll let you know what's up. I'm trying to figure out what's going on. Nothing's good. Nothing. There's no improvement. Hey, I can't fix this, partner. I'm screaming from the back. Let's go. Lights and sirens. Let's get to the hospital. But that's me. 5 minutes, 6 minutes, 7 minutes, depending on my partner, depending on the call. But I'm rushing, dude. I'm fucking going. And as you could see, those who have seen my old videos, you could pretty much say that, yeah, I should be right? I'm not bullshitting. I'm working quick. I'm doing shit. So that's pretty much it, guys. Another thing that I wanted to show you the differences between adult patient assessment and pediatric assessment, and I'll show you here, is this. It's the same thing, the same primary assessment. You just can't get chief complaints from a patient. You can't get, level of consciousness too much, right? Like depending on the age group, you can't get, name, time, person, event, right? Because they're not conscious enough. They don't have situational awareness of their environment of life yet, right? So how do we find the things that we need to know to determine they are okay, right? So this is the only difference is, and as you can see here, ABCs, but instead of airway, it's appearance, right? And let's read it through. Pediatric initial assessment algorithm, or in other words, you can see right here, PAT. Pediatric assessment triangle, right? Form and general impression. So let's start off. Evaluate scene safety and situation. What is that? Scene side stuff, right? On the patient assessment. Additional resources needed. Second unit, supervisor. I mean, you never know, right? Should happen. That's why they're there, right? To help us. Okay, now we're in primary assessment. Look at that. General impression. 60 seconds or less to complete. So, instead of airway, we're doing appearance, because we can't get a mental check, mental status. We can't get a level of consciousness, GCS, or more of a COA, right? COA times 4 out of them. So this is where we go here, right? Look, appearance reflects the adequacy of oxygenation, ventilation, brain perfusion, homeostasis, and central nervous system function, which is LOCs, brain, remember? Neuro. So now here we go. This is the little acronym we use. TILCS, TICLS. Tone, inactivity, mental status. Consolability, which means, can the parents calm down the patient, right? Pretty much. Look, gaze, speech, or cry. So this, I'll give you a pointer. Do not touch patient or get too close without doing this first. Work of breathing. You want to get a rate first. Because children, especially like 5-year-old, less than 5, 6, less than 6, they're very fearful. Well, mostly less than that, right? Like 2-year-olds, 3-year-olds. Right? They're very fearful. They're very skittish. They're very cautious with strangers. So you want to get a baseline of rate because respiratory rate is a very good indicator that something's going on before heart rate and blood pressure changes. And I'll go into details later on. It's a different story, but a different video. But get a rate because as soon as you touch them or get close, this goes out the door. You don't have a baseline anymore because they're crying, they're angry, whatever. They're non-compliant. They're moving around. You can't get a baseline. So do this before all the rest. Before you touch the patient and before you get too close. And please, please, please tell your fucking partners what you're about to do because I've been in those situations where I was like, hey, hold on. And they don't listen to me or whatever. They ignore me or they don't know what the fuck's going on. And I'm trying to read the rate off the patient from a distance and then go make contact. Hey, buddy, how you doing? Blah, blah, blah. Let me hold on. Let me hold you. And fuck, there goes my respiratory rate. All right. So please, please let them know until you're done with this. Then you could, continue the assessment. But anyways, airway breathing circulation, breathing, body position, visible movement, ventilatory rate, ventilatory effort. Right. Breathing reflects the adequacy of airway, oxygen, and ventilation. Circulation. Circulation reflects adequacy of cardiac output and perfusion of vital organs. So another pointer when it comes to pediatrics is the leading cause, the number one leading cause for cardiac arrest in the pediatric community or patients is breathing, respiratory illnesses. So breathing, airway, on respiratory are very important, much more priority than adults. So work fast, work quick on this to prevent death. And this is where we go, circulation, skin color. And that's pretty much it, man. That's the only differences. So there's two differences when it comes, there's two changes depending on the situation when it comes to patient assessment. One is unresponsive. We go from ABC to CAB. And then when it comes to adult, to pediatric, we focus more on primary assessment in a different format, but it's pretty much the same. You're trying to find the same results, but you're just approaching it differently, right? And so that's pretty much it on that. Hopefully that makes sense to you guys. Hopefully I was able to, help you out and explain. If you already knew all this, then disregard me and move on. But let me show you something else, guys. A little EMS life hack. And as you can see in my note, this is my folders. This is the shit that I keep, to refresh myself and, things I've gone through and kept notes of and stuff like that. But I want to show you the EMS field guide. This is a copy, electronic copy. I actually have a physical copy, and this is the second edition that I made maybe about 3 years ago when I did the flight medic. I had to update my original field guide, and that field guide was created when I was in paramedics. I was a paramedic student, and the concept behind it is I understood my limitations as a human being when it came to information. I knew that I wasn't going to remember everything, and I knew everything that I was encountering was very important. So then I thought, well, how can I hack this? How can I not have excuses? How can I not put myself in a position of vulnerability and then put a patient at risk? So I then created my own field guide. And so, as you can see, it's full of information. All this, it's all in my head somewhere, somehow. And just to refresh my brain. So there's no excuses, guys. Be a professional, act accordingly, and don't give excuses that, it's, I don't get these calls often, so it's not my fault. Like, no. You see, like that. And I understand, like, we're not going to see this shit all the time, but hey, we are the help. We're supposed to be there to help. Who else are they going to call? Who else? Like, And so, see, this is all important information. You know, I thought about making books about it. Maybe in the future, I could put these on sale. But honestly, you can just do it yourself, guys. I mean, don't be fucking lazy. Make your own field guides. But if you want to be lazy, then pay me, and I'll send you a copy of this shit. Send you a PDF copy of it. And if not, then fuck it, whatever. But anyways, uh, thanks for everything, guys. Thanks for watching. Hopefully this helps you. Let me go back to here. Hopefully this helps you. Hopefully I was able to help you see this in a different perspective. Um, if I forget anything, I'll put some captions on it. Probably not. I'm feeling pretty lazy today, so, and it's my off day, so fuck it, I'm gonna relax, right? But hopefully it all works out. Hopefully it helps you, and yeah, I'll see you guys around. Stay wild, guys.